welcome back everyone. We are here for another dose of Joint School, and today I'm delighted to have with us Jackie Walumbe. Jackie is an advanced practice physiotherapist at University College London Hospitals, where she works as part of a multidisciplinary team in the field of complex pain. And Jackie is also currently completing a PhD at Oxford in this topic, and will today be helping us to explore and further understand pain and what it means and how we can manage it in different ways. Is there anything you'd like to add to that introduction, Jackie?
No, thank you very much, Axel, for having me. It's I think an important topic to think about pain, and there's a lot of misconceptions and misunderstandings. So really looking forward to a conversation to try and unpack what is really quite a big topic.
Yeah.
That we all talk about as if it's something very simple. We talk about pain, but I think there's just so much that might be useful for the participants, people watching. So yeah, really looking forward to it.
Yeah, no, thank you for joining us. Thank you for joining us. So I guess should we start perhaps by learning a little bit about you and your career in healthcare and how you've come to focus on pain in particular?
Yeah, absolutely. So I trained as a physiotherapist in the UK, and as part of your training, I did a little bit about pain, but I think the general training, as with most healthcare professionals, was that pain was a result or a symptom of illness, injury, or disease, and therefore you fixed that bit and you hoped that the pain would get better and go away. And once I started practicing as a physiotherapist, I worked in many different areas, as is part of our training. So covering what you'd think a physiotherapist does in musculoskeletal health, as we call it, or even orthopedics, so the kind of joint stuff with people having operations, but also some of the less known areas such as neurology and working with the elderly or older people. I spend a little time just really orientating myself around health services and decided to specialize in the area of musculoskeletal care. And so I spent a little bit of time working and building up my skills, and slowly started to get a little bit frustrated because all the things that were supposed to work for most people worked for some people, but didn't necessarily, not in the way that it was kind of put to us in training. So I think my natural response to that was to try and learn more and do more, go on courses and do things better. And I think that's when I really started to see that there was a difference in how people were experiencing pain. So they might have the same kind of problem, say something like knee problem or knee pain, but then different people had such different experiences, and they found they were coping in different ways. So some people were fine with a bit of advice and off they go, but some people were really struggling, and this might even be after having operations, which on paper looked beautiful, but in reality they were still struggling with pain. So at that point I decided to do some training and went ahead and did a master's degree, focusing on pain science and society, and that was at King's College in London. And that was just so helpful because, as well as understanding the different ways that pain could be understood, by that I mean understanding not just the body and anatomy, which I was very familiar with, but with the neural stuff. How do nerves and your immune system contribute to how things are, but also how does your place in society, how can that contribute to what's going on for you on a on a personal level. So that was just fantastic for me, and I went then into a specialist role focusing on what we call chronic pain. Chronic pain, for us, really is an understanding is pain that has gone on for a lot longer than expected, and all the kind of the tissue, so the body bits, seem to be all right, and there's nothing too bad about them to explain the amount of pain. So I took a role and just focusing on that group of people, and the work that we did in that role was the beginning of multidisciplinary, so working with different professionals, but mostly alongside a psychologist.
Okay.
And I know a lot of people might think, why on earth would you be working with a psychologist? Um, but I think it's because with chronic pain, having pain for a long time can be so difficult for people, and they find that the longer you have pain, it might start to affect your mood,
Mm.
your ability to feel motivated to go to work and do those kind of things. And for some people, it affects your job. You might lose your job and not be
Yeah.
able to do it. So working with a psychologist, I think, was so helpful for me, where we were able to kind of look at a person not as a mind and a body, but
Mhm.
as a human being, where all those things kind of messily interact.
Yeah.
And since then, I've just worked in that area, in that field, but moving from setting to setting. My current role, where I am now, is slightly unusual in that um, we see people in hospital who have long-term complex pain. By that I mean it's just a little bit harder to manage than you would expect.
Mhm.
And this would be across the whole hospital, which can be quite unusual for people. So we might see people with bowel problems, so the gastroenterology, or sickle cell disease, or people coming to accident and emergency struggling with a flare up of an existing problem. So that might be your hip, your knee, your back, but
Mhm.
also headaches and other areas. And to do that, because pain is now understood to be quite complicated. So it involves so many different aspects of a person's life. So we do have a big team which covers, we work with pain doctors, pain nurses, pain psychologists, pain physios. So what we have in common is we're all specialized in focusing on pain, but
Mhm.
really working as a team to try and help the other members of the hospital teams to get their patients more comfortable, not just with medication, but a whole bunch of other things that maybe we can touch on later on.
Yeah, yeah,
So
absolutely.
yeah, so I think that's kind of where how I got into the field that I am in.
Okay, well, interesting. I mean, I think there's from my point of view, I feel there's certainly been an increasing understanding of pain as something that is, intensely unique and personal, both in terms of how it arises and how it impacts our quality of life and so many different other aspects. And so it's really interesting to hear more about the forefront of how this recognition translates into how we manage these different scenarios. And I think it's one thing to sort of say and recognize that it's a unique experience and it's going to be different for everyone, but how do we then translate that into how we approach the management of pain, and what are the tools and techniques that might help in different scenarios? And of course, because it is so unique, there's no one size fits all, but I guess I'm a little bit hopeful that we might hear some clue as to as to what you find, if there is a sort of one technique or one tip that you could unpick, or that if you could click your fingers and or yeah, and everyone would be able to embrace in terms of self-management. What would that be?
So can I answer that in a bit of a convoluted manner? So
Well, I guess that would be a good match to a bit of a convoluted question.
yeah,
Yeah,
so,
yeah.
so I think one of the key things that I suppose I'll answer your question to start off with and then unpack it a little bit.
Hmm.
So for me, and what's generally been recognized is that a person's experience of pain is usually quite scary and
Hmm.
alarming, because all of us pretty much in modern society have that belief that pain equals something wrong. So therefore, if you then have a scenario where there's no clear or reasonable explanation as to why someone has pain, that can cause an untold amount of distress, uncertainty. It's just really hard for people to hold that "what do you mean you don't know what's wrong with me" question. So I think the key cornerstone, I think, for most people is to have a workable understanding of why they have pain, that
Mhm.
makes sense to them. Now, that can be across the board. So, for more early, what we would call acute pain, and maybe we can talk about definitions,
Mhm.
is if you have pain that, say, you fell over and you twisted your ankle,
Yeah.
you straight away have a relation. You can go, well, I fell over and I twisted my ankle. Now my ankle looks like this and it's sore. So
Mm.
that usually is not that distressing because most people can go, oh, I've sprained my ankle. There's a route. You know who to see. You might see your general practitioner. You might go see a physiotherapist or an osteopath or whatever. But it tends to be, there's a cause and an effect, and therefore
Mhm.
things are fine. Where things get a little bit more complicated is when we think about the body healing.
Mhm.
So when we're thinking about definitions of pain, they're really related to this time thing. We're a little bit obsessed by time. So the idea that pain that is early on is usually considered, um, it can be very bad, absolutely, but it's not as difficult to manage. The
Mhm.
health system is ready, is set up to take care of people with acute pain. So if you
Mhm.
broke your ankle, no problem. There's surgeons who are ready to sort you out. There's rehabilitation. There's a pathway for you to take.
Mhm.
Hopefully, as your body mends and heals and repairs, so your bones will knit together, your ligaments will start to get a little bit stronger. Any muscle tears will start to heal. Bleeding stops. All of that process of tissue healing and repair is really well understood. And as long as your pain matches that trajectory, most people, you're not that concerned because you might go
Mhm.
for a follow-up appointment and say the surgeon that has done the operation will go, brilliant, at this stage that's exactly what I was expecting. I was
Mm.
expecting the pain to be a bit less and for you to be able to do a bit more. Where we then have more, a little bit of a difficult boundary. So the time zones are according to the International Association for the Study of Pain. And that's really the biggest body where we kind of all agree we get most of our definitions from. So they say that pain is it's a sensory and emotional experience related to actual or potential tissue damage. Now, there are some variations in that definition, but we won't go into that for today's purposes. But the key message is there: sensory, it's telling us something about what's happening.
Mhm.
Emotional, it affects kind of our mood. It's an experience. So really talking about that the personality, it's personal. It's
Mhm.
an experience. So it's not what you feel or I feel. It's a very personal experience, and it's related to actual or potential tissue damage. And this is where you then start to think about different ways of thinking about pain, where they say maybe it's not accurate. Just because I have pain doesn't mean I've injured myself. And you can get some really nice examples when you think um, about sport. If for people who are involved in sports, if you're watching telly and so the Olympics, for example, there's a few clips on YouTube that watch with caution, of say a long jumper going to jump and they kind of land on their foot and the foot, their leg breaks in half. Horrible to watch. But their facial expression is one of, you know, they're not going, ow, they're just going,
Mm.
something's wrong. And they continue to try and complete the jump. So not really having an immediate connection of pain and damage. And
Mhm.
it's only when perhaps they look down and look and see the mess that the pain kicks off, and similar things on the other side where football, for example, someone goes to slide to take a kick, a very important um, kick in a match. I
Mhm.
do not know sports, by the way, so if I get they just go kick the ball for something, they slip and fall
Mm.
and they think they've injured themselves, as well as maybe it's time for the final bell, their team's not
Yeah.
winning, and everyone's really concerned about this foot, it's terrible. But then when they go off and do all the tests afterwards, your MRIs, your x-rays, nothing.
Mm.
Tissue is in good health, but the person is experiencing pain. And those switches of when you're having a bad day, knocking your toe feels horrible, but when you're having a good
Yeah.
day, you knock your toe and you just hop and skip and you carry on with your day. So I
Yeah.
think those real life examples have started to show us that it's important for people to understand that pain is not a purely accurate indicator of what's happening in our bodies. It is important, but sometimes when time has been going on for longer and longer, the mix, the contribution of like the body issues starts to change a little bit. Now,
Yeah.
in the past, they used to talk, not in, I say the past, but some of people may have experienced this, where you're told, you know, you have really terrible knee pain, you go and get an x-ray, and someone says, your x-ray is actually not that bad. So I don't know why you're, you know, what's going on. Then you get an MRI and they go, no, it looks pretty good.
Yeah.
So that can be really invalidating, because you can feel the pain, but you're being told there's nothing too bad going on.
Yeah.
But then there's also the flip side. Yeah, so you can get someone who's pretty much not looking right in terms of how their knee looks, and they've seen their GP, they've been sent on to surgery, and they're going, I don't have any pain. Why are you trying to operate on my knee?
Yeah.
But then when you look at the imaging, it can look really terrible. So there's not always a correlation between what you see on your scan and what's happening for the person.
Absolutely.
And it's about, so going back to that question is, if somebody cannot make those two things resolve, it can actually be very, very threatening as a, well, if you don't know what's going on and you're the expert, my goodness, I must have some terrible, horrible thing that you've just not found yet.
Yeah.
So newer explanations about pain are coming up. They're not universally agreed on, but on the whole, the sense that the nervous system is involved and the immune system is involved in how we as human beings perceive threat. So it's a little bit about evolution. Is when we think something's wrong, our body does a whole bunch of things to protect us, and pain might be one of those. And even more advanced thinking around that suggests that actually our brain predicts what might happen in the future,
Yeah.
and preemptively decides to prep you for the thing that it thinks it's going to happen. And so we start to see a really nice matchup of how we think, how we feel, our personal circumstances, how those can actually directly lead to or contribute to pain. It's no longer you're mad. It's not all in your head. It's not all in your body. We are a human being. So for me, the intervention that's the most important that all healthcare professionals can do is to offer a credible explanation that makes sense.
Yeah.
So if someone believes very much about the anatomy model, you might use anatomy a little bit to try and explain it, but when you get into that big gap, maybe it's better to have some knowledge around how the nervous system can contribute, how your thoughts and emotions can make things better or worse.
Yeah. Yeah. Yeah.
So that's a
Absolutely.
very long answer.
No, I think it's a very valid one, and I think, I mean, in some cases, certainly, I imagine in some of the complex cases that you may encounter, taking an anatomical approach might not always mean that there's an exact answer to what is going on, but a surgeon or another healthcare professional might be able to say what's not going on, and that can also be the other side of it. And I think there's a bit of a sense in what you're describing of us as sort of emotional beings floating in this soup of context and expectation. And I guess, you know, with that, how can we try to find some agency, or rather enable people who are in these tricky situations, these painful, uncertain situations, to find a bit of control, to find some agency, to try to guide against and set expectations and find some kind of empowerment within that?
Yeah, absolutely. So in terms of so we tend to focus on this concept in pain management, which is around what an individual can do. So formally we talk about the biopsychosocial model. So that is very much biology and psychology and the social all intermingled in one messy soup bowl,
Yeah.
and picking out what matters at which point. So the psychological side of things is usually framed using trying to understand how a person's personal individual capability allows them to do things, or to be more empowered, as you say. So we talk about something called self-efficacy, which is just saying that do you think that you've got the capacity and the capability to do things to improve your situation? So if you have that kind of belief, you tend to do better, even if you have a terrible health problem. Is that if you have that belief that, yeah, I can do something about it, you do better. The only thing we're starting to see, though, is that people who have self-efficacy, it doesn't come from nowhere. It tends to be because in life you've had some good chances, you've had a good education, and you've managed to get a good job, and when you apply for something you get it, and you've got a good comfortable house, your family is really supportive, and your workplace is so important when it comes to pain. Your workplace says, no problem, have some time off, recover. So that side of things is not necessarily in people's individual hands, but as long as we acknowledge it's there, that individual capacity to go, I can do something for myself, has been shown to lead to better outcomes. And I'll give you a practical example, would be, if we keep with a knee problem that we've been talking about, is if you have a knee problem, and say you were running, you were doing a little bit of couch to 5K, and your knee flares up and you're just like, "Ugh." So if your belief system is that my friend's uncle had a knee problem and it ended up being something really bad, you might automatically think my knee problem is also really bad. And so you might start to do some experimenting and testing and say, let me just check. Does my knee straighten and bend? What if I try some ice on it? Oh, ice didn't feel so good. Maybe I'll try some heat. Or someone I know mentioned that there were some stretches that they did that helped them. Or maybe I hop onto YouTube and go onto Joint School and you watch some videos, etc. So that is self-efficacy. That instinct to try things out, to look into it, will serve you well. And so where our role is to make sure that the type of information that's available is helpful and doesn't just say things that might not be that helpful in the long run.
Yeah.
Yeah.
So,
So
so I guess we can give a big thumbs up to everyone watching this and say, you're practicing self-efficacy.
yeah, you're already well on the way because you found a source of information. And now the key thing here is information alone doesn't, it's not it. Information might help you think differently about the problem, but what you then need to do is use that information to do some of the practical stuff that makes a difference. So it's hard to talk about everyone's pain, but broadly a lot of people want to be able to move. As human beings, we're interested in movement as a thing, because movement allows us to engage with the world. It allows us to you know go be with family. If you have grandkids, they want lifting and tossing about, and I'm saying this with the caveat that not everybody has the capacity to move, so with certain disabilities and stuff. So it's not about making people fixed, it's really about looking at, what would you like to do, where are you stuck, and then here's some information, brilliant. But then from that information, the next step is, setting some goals, thinking about what next, what would I like to do, and then listing some practical skills like, can I do it? when can I do it, with who, really unpacking the details of how, and then the perfect, the ideal step would then do it and then try it out, experiment. Um, and it's not about doing it and everything's fine 100% of the time. It's about trial and error. Um, all that stuff we've been told, by teachers is you chip away at it. You go 2 steps forward, you might go 3 steps back, but that's okay.
Yeah.
Yeah, that kind of thing.
Yeah, absolutely, and even the process of setting goals, and that itself is a step towards this, right? And talking about those goals with your partner, with family members, with your healthcare team, and providing a bit more context. It's where things like the Joint School app or other versions of the myrecovery app, just tracking how you're doing, how you're going with symptoms, how you're moving towards those goals, or even linking in. Most smartphones these days will count the number of steps we take each day, and that, putting that into the context of sort of a treatment journey, or just in the context of hip or knee arthritis, and seeing how that changes over time in the Joint School app, for instance, can give a real measure of where you are now, where you were before, and what has the impact been of perhaps different treatment interventions, different approaches to managing pain, and it can also be something that, again, gives you as an individual a sense of something that you can have a bit of control over, something that you can bring to your surgeon or your healthcare professional and see, this is where I was, this is where I am now. What do you think about that? How does that change the plan for my next stage of treatment, or for what we do over the next 3 months, the next 6 weeks, whatever it may be?
Right, absolutely. And it's so difficult because when you're well, you're
Mm.
just doing things. You don't know what you're doing or not doing. You're off. When you're not feeling at your best and when pain is present, it can be really hard to notice the achievements.
Mm.
You might have actually done brilliantly well, but because you're still focusing on maybe comparing yourself with how you were before, it can almost be, oh, I'm no good, I'm
Mm.
making no progress. But having those markers, or you know things to own, just something to look at and go, 3 weeks ago I may have struggled to climb out of the bath,
Mm.
and then but actually that was a little bit easier when I tried that last week, so
Mm.
maybe I'll keep note of that
Yeah.
and see what happens in about 4 weeks time. So you're right, this keeping an eye on, it's not necessarily tracking, but this information can be so helpful to keep us motivated,
Yeah.
particularly when if it's a really rainy cold day and
Mm.
everything aches and there's no sunshine, that's a hard day to motivate yourself. So you might look back at if it's a journal, if it's an app, if it's some pictures on your phone, whatever it is, you might look back and go, actually, I was able to do this. So it might just give you that extra oomph
Yeah. Yeah.
to keep going.
Yeah, absolutely. I mean, and I guess that's one of the key challenges, especially with severe and persistent pain. That it's easy to find people suggesting that, well, it's a positive mental attitude and motivation will see you through. But few things are more demotivating and negatively impacting on your emotional well-being than pain. And so there's sort of an inherent, almost not necessarily contradiction, but that's certainly a core challenge with that whole experience, and trying to sort of find ways of almost, I guess, on the tougher days, almost tricking yourself into taking those steps, or motivating yourself, or somehow finding some kind of framework, perhaps with outside of yourself, that can help to sort of
Mm.
overcome the trickier days.
Yes, absolutely. And so with chronic or persistent pain, so this more lingering pain it's just there with you all the time. Sometimes it's bad or not. We know that goes up and down.
Mhm.
You will have good days, you will have bad days. Some people recover from that depending on obviously what's happening for them. Some people don't. So many people live with long-term pain even after they've had medical interventions and rehabilitation. So because we know this is going to happen, a good healthcare professional is going to warn you and prepare you for the bad days. So it's not just going to be like, brilliant, I set my goal, off I go, up, 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 up. You might get there and then, oh no. So it's the trick is, what do you do on those days when things aren't going as well as you'd hoped? It might be, so we talk about flare-ups. Flare-up being when your pain goes a little bit beyond your capacity to cope with it. So you might be coping well, but then one day it's just too much for you. And that might be because the body, the anatomy does something. It might be because your mood takes a shift. It might be something in your social life that just, a relationship breakdown, all sorts of things. Whatever the reason, you have that dip. So what we ask people to think about is, when you're feeling at your best, is to take note of that, is to write out a flare-up plan going, when I'm going, at a time when things are low, what would I like to have in place that's going to help lift me out of that, so that you're not thinking about it when you're down there. When you're really, on it, you're thinking, actually, I might want on my flare-up plan, and that's very individualized. So some people might have medication on it. That's absolutely fine. You might need medication that you've discussed with your doctor or your prescriber, that says, this is something I want you to take at this dose when you're at that point. So you might have medication on your list. You might not have medication. You might have something that's more focused on the app, for example. You might be revisit something that you'd learned before. It might be that you look at spending some time on your own, maybe reflecting or doing some relaxation or mindfulness work, or some focused activity. Or so some people in their flare-up plans have movement and activity, which might feel very against your instincts, but some people find movement really helpful to help them come over. It might not be at the same intensity as before, but it might be, maybe I won't stay in bed for 10 days. I might stay in bed. So rest as well is completely normal. I know sometimes physiotherapists were a little bit known for, keep going, but rest is a valuable tool. If it's, it's part of your flare-up plan, you might need to take stock. But also something you've mentioned as well, Axel, is, who do I need around me during this difficult time? Is it that I have my healthcare professional team at hand, depending on which system you're working with? Is it that you can call someone to check? Or is it someone you can go and see? If you don't have that, is there a family member that you want to have on hand, a carer? So having that flare-up plan written over time and having it pinned up ready to go, with maybe a box of, if we're thinking practicalities, do I have a shoebox that I put all my stuff in it, or a playlist that I know is ready to go? Those kind of things have been, for our patients working with long-term pain, they've told us that that's remarkably helpful.
Interesting. Yeah. So it's sort of putting together like a toolkit for the rainy days.
Absolutely. Because it's like, when it's a rainy day, you just don't have the motivation. So this is just, you're tricking future you and going, haha.
Yeah.
This is what I did before. Here's one I made earlier.
Yeah. And I find that quite an interesting construct as well. This idea of looking after the future self, present self doing things that's going to help out the future self.
Yeah, absolutely.
Yeah, interesting. And also, I think another important point that you raised there is around the role of physiotherapy as part of a way of managing pain, and that can be, whether it's to do with persisting or chronic pain related to knee or hip arthritis, or it's part of trying to build some muscle and flexibility before surgery, or indeed even after surgery. Like, as I'm sure many people watching this video now will know, it's really important to get moving soon after surgery for a number of reasons that beyond the detail of this conversation, but certainly pain management is one of them, and getting going. And even though sometimes it can feel a bit counterintuitive. And I think in other videos, other interviews, we've spoke about finding that balance between, you know, keeping active and keeping moving, but also embracing the rest days, and, you know, and understanding the value of rest. And then, but then within that, there's and we've had some really good questions sent in about, well, it hurts when I do the exercises. How do I know? You know, how do I know when to stop in terms of that? Is there, and in a couple of cases, there's been this concept raised of sort of good pain and bad pain, and trying to understand which is a really, you know, which is a difficult concept, and it's sort of understanding sort of, well, at what point am I is my body telling me to stop doing an exercise, and at what point is it a barrier that I need to start sort of pushing towards to progress?
Yeah, I mean, and that is such a critical issue, because like rightly so, because our understanding of pain is based on pain being an accurate indicator of what's going on in my body. Therefore, if it hurts and I push it, I'm obviously doing more damage. So if we think about so hip and knee arthritis, for example, you know, these processes have happened over time. They didn't happen overnight. So you may have had arthritis in your joint for years and years and years, but you might not have had pain for that entire time.
Yeah.
That's important to remember, is even though it's tempting to use only pain as the judge of what you do, what we encourage people to do instead is the longer you have pain, the less accurate pain tends to be, because we know the system becomes more sensitive over time. You're more likely to feel pain doing less. You might even have pain doing nothing. So what instead we say is, there's a bit of work to know yourself, to know your own body, and to know, you know, we talk about trial and error and practice. And so rather than, most physiotherapists are not going to tell you do this exercise no matter what.
Yeah. Yeah.
They're usually really interested in you
Mm-hmm.
coming to the table and going, so we talk about the concept of pacing activity,
Yeah.
where you start low, you find a level of activity, and we're really knocking off a fair amount of whatever that is. Say walking.
Mm-hmm.
Say somebody used to walk when they were 40, they used to walk 25 miles a day. But over time, that slowly chipped away, and now they're really struggling to hit, say, 2 or 3 miles a day.
Mm-hmm.
So when they start their program, the temptation is, well, I used to do 25 miles at some point, so off I go. Now we know, if we're thinking biologically only, even just that, your body's going to be like, what? You know, what are you doing? Because you need time for those tissues to build up, accommodate, and get used to movement. So we might say to somebody, let's think about what you've done in the last 2 months,
Mm-hmm.
not when you were a superstar athlete in high school, but in the last few months, what's your activity level being related to walking?
Mm-hmm.
And then how did you get on with that? If people don't remember, we start from today. So we say, starting from today, just keep an eye out using your phone, your app, or keep an eye out on how many steps you do just regularly. And say it tells you you're doing 3,000 steps a day. That's brilliant. It's telling you that's about what you're doing. So it might be that for your homework, your movement activity, you might start at a target of exercise, not of your general movement, but you might say, I'm going to start walking for 1,000 steps a day. So on top of my normal movement, I might start with it might seem really tiny, but what you then do is you build that up, you keep going, and you will do that on good and bad days, because it's an amount that is tolerable. It's not going to really do much, you know, injury to you. And then what you might do is, over the course of 3 or 4 days, is build up in increments, tiny increments. Usually we talk about 10%. You might say, after 4 days, 10%, let's see. Now 10% of 1,000 is not very much.
Yeah.
But when you get to, say, you're doing 6,000 steps a day, 10% of 6,000, these slopes tend to look overall a bit exponential, really slow to start off with. And then when your confidence has built up, your tissue tolerance has built up, your muscles are stronger, you know, or you're a little bit more comfortable with flare-ups. You know what to do during a flare-up. It might be that you then have that, you can push yourself a bit more,
Yeah.
and you know your body better at that point. So it's no longer a, I have pain, should I stop? There's no simple answer there. There's a bit of work to do to get to the point where you are able to say, actually, I've done everything I normally do and I'm struggling here. So this might be the point you reach out to your healthcare professional, but it might be, oh, I've been here before, not a problem. I have a toolkit. I have, I know what I'm doing,
Yeah.
and I'll build things up. And there are resources out there that maybe I can mention at the end to add to the video.
Yeah, absolutely, absolutely, and I guess that comes back to the idea of, many of the concepts that you've raised of like listening to your body, understanding what's normal for you in the current situation, having a pack or a toolkit or something in place for a rainy day, and also like the social support around you, and linking into that. It, there's so much more that we could we could talk about. I think we may need to do another session on this, because I think it's probably coming to the time where we need to start thinking about drawing this conversation to a close. But is there anything else you would like to add? And then of course also these other resources, if we go through and mention them, and I'll make sure that we put links to them appropriately beneath the video as well.
Yeah, absolutely. So I think maybe a key thing to think about is pain is not always as simple as we think. That doesn't mean it's like, oh my God, it's damaging and scary, but so many different things can contribute to how we experience pain. And therefore, if we can target the whole range of things that influence pain, we might have more at our hands than maybe only the I need to see the doctor or I need just the tablet. It might be that there's a lot more you're able to do on your own. So what tends to happen is, if we think about resources on the web, so I can start with the Physiotherapy Pain Association, where I'm the vice chair of that. There's a page that's just got a list of different resources that's been brought together in one place, that includes things around mindfulness, meditation, compassion, things that you might not be very familiar with, but you can introduce yourself to that, as well as more practical tips around movement, activity, pacing, and this idea of pain education and understanding pain. There's a few videos on YouTube that focus on understanding pain from a neuroscientific perspective. A lot of that work has been led by Professor Lorimer Moseley, who's over in Australia with a lot of colleagues around the world. And they as part of the Neuro Orthopedic Institute, I think it's called, NOI, but their focus is very much on generating books. For example, one called Explain Pain, which has a very simple, it's complex concepts, but it's very easy to understand. But moving right across the spectrum to, there's a website called Living Well with Pain, and that's run by a group of volunteers, but includes, Dr. Francis Cole, who's a GP who's done a lot of this work. So lots and lots of resources there around activity management and pacing. You've got Pete Moore, who is someone who himself has had pain, and he runs the Pain Toolkit website, which has lots and lots of useful tools and resources in different languages as well, if you were interested in that. And then there are the various blogs, etc., where you'll come in touch with that. But one of the things that we found really, really exciting right now is something called the Footsteps Pain Festival.
Okay.
Now that is run again by a group of people who are living with pain, and they're doing a year-long festival where they're looking at all sorts of non-traditional ways of thinking about pain. So they've got cooking and pets and nature walks, and it's all online, so that's accessible via the Living Well with Pain website. but perhaps that's a good start for people thinking quite generally about having long-term pain, and they want some ideas about where to go with it.
Yeah, great. Well, thank you so much for sharing all those tips and resources, and for joining us today. To those of you watching this, thank you for watching. It's a great, step, another self-efficacy step, and I do hope you find this conversation helpful, but also some of the resources, and I'll make sure that there's links here below. Do let us know what you think about them and which ones you found most helpful, and also if this conversation has sort of sparked any other questions, do send them in, and we'll get to them in an upcoming interview. So thank you again, Jackie, and thank you everyone for watching. Stay safe out there and keep up the good work. We'll see you next time.